Hi, I'm Darlene Hamblen. I'm here to talk to you today about just a little trauma assessment. This is a pediatric trauma assessment, and we will review several things today. The first one will, of course, be the primary and secondary survey. Your primary survey, as you can see, is very similar to your adult trauma assessment. We're going to cover airway, breathing, circulation, disability, which I also like to call neurological status. We always want to make sure that the patient's airway is patent, being able to move air in and out of the airway, that the airway is competent, that the patient is able to maintain their airway on their own without any airway adjuncts. We also want to make sure that there is nothing that could cause obstruction of this airway. These things we're going to talk about in detail. You want to make sure that the pediatric airway is open, and there's a lot of things about a pediatric airway that's anatomically different from an adult airway. Number one, the airway is much smaller. The trachea is much smaller and shorter, so it's more easily occluded. The occiput in the back of the patient's head, is much larger, so when they are laying in a supine position on a long spine board, you have to be aware of that because it will actually tilt their head down and occlude their airway. So you'll need to pad beneath the shoulders all the way to the all the way down the torso, and by doing that, they can actually increase the opening of the airway. You also want to make sure that you are aware that the tongue is much larger in comparison to the oral cavity. So the tongue is very much the number one culprit for occluding the patient's airway, especially when they're laying in a supine position. The tongue will fall back and occlude the airway. The epiglottis is much more floppy and it's U-shaped, so that can also occlude that airway. So you have many different components that you have to be aware of when assessing a patient's airway or a pediatric patient's airway. The next thing you want to look at is their breathing. You want to make sure that the patient, number one, is breathing, and is the breathing adequate. If they are not able to move air both in and out, then their breathing is inadequate. There is an increase, you want to look to see if there's an increased work of breathing. Children do things that adult patients do not do as far as work of breathing. They do things. Nasal flaring is something that you see actually across the gamut of the patient, the trauma patient, and that is a sign of increased work of breathing, and they're trying to open their airway up so that they can move air in. They also, children, and I've actually never seen this in an adult patient, is head bobbing. They will elongate their airway so that they can actually move air in and out a little easier. Pediatric patients are also diaphragmatic breathers. Their rib cage, their intercostal muscles are not as strong as the adult patient, so they rely on their diaphragm to create that negative pressure within the thorax to bring air in, and they are diaphragmatic breathers. So things that if their abdomen is distended, or anything that can hinder the movement of that diaphragm can also hinder their breathing. Oh, I'm sorry, something on this slide that I did not point out. The adult airway is usually around 20 millimeters in diameter. So if you get 1 millimeter of swelling or edema circumferentially, then you're going to have about 4 millimeters total. That's going to be about 1/5 of the diameter of the airway for the adult patient. However, with the pediatric patient, their airway is usually between 6 and 10 millimeters. So let's go with a mid-range number there of 8. And if you get 1 millimeter of edema or swelling around that airway, that's going to be 4 millimeters. You just cut that airway in half. So that is a huge anatomical difference between adult and pediatric airways. And that is one reason why a small amount of edema from a trauma such as a fire, smoke inhalation, this is something that you need to definitely keep in mind. Now, We're on to C, circulation. Does the patient have a pulse? That is always the first question you ask. If the patient has a pulse, what's the intensity of that pulse? How well are they moving their circulating blood volume around their body? What's the skin condition? The skin is the largest organ in the body, so it's also not considered a vital organ. So in times of trauma or hypovolemia, the patient is going to shunt blood away from their skin, leading to mottling, a coolness to their skin, diaphoresis. This is what brings all of this around. You also want to know if there's any active bleeding anywhere. Now, the difference between pediatric patients anatomically than adult patients as far as the circulatory system goes is sheer volume. A normal pediatric patient has approximately 80 cc's of blood flow per kilogram. So if you have a child that is 10 kilograms, then their entire total circulating blood volume is 800 cc's. That is less than a liter. I don't know if y'all have ever been in an adult trauma resus, but I have seen them give units and units and units of blood. You can lose a lot of blood very quickly, long bone fractures, solid organs, and you can lose it without seeing it. So this is something that you need to keep in mind, that in pediatrics, their total volume is much, much less than what's in the adult, which is typically 4 to 5 liters. Now, another thing about children and their circulatory system is they can compensate very, very well. They will actually, before they show signs of a decreased blood pressure, can lose as much as 50% of their blood volume. So you will be way behind the 8 ball before you realize it if you're not watching for these subtleties that they show you, which are things like delayed cap refill, cool, clammy skin. Children will get cool at their fingers, and then it will progress as they lose more and more volume. It will progress to their hands. You'll feel their feet get cool, then they'll be cool to their knees, and you need to monitor this. One set of vital signs, it's very important for you to monitor your vital signs, but the thing that you need to remember is one set of vital signs are not very helpful. You have to trend them. So you want to keep, and when I talk about vital signs, cap refill to me is a vital sign. That is something, temperature, that's a vital sign. Kids get cold.